clicker. Oh, thank you. Is this the wrong one? Is this a good one? Well, thanks to all of you for sticking around through these amazing sessions. I know I've learned an awful lot today and continue to learn from some of these great leaders throughout the entire world who teach us great concepts related to image-guided approaches. Dr. Dewan asked me to conduct this final talk on bundling. Now, this is really something for those of you who are, like myself, clinicians, which is the heart and soul of why we do what we do. First and foremost, we want to be safe for our patients. We want to provide technologies and techniques that demonstrate efficacy with low complication rates. But if you're going to maintain any modicum of a successful practice, you've got to get paid for what you do. So I'm raining on everyone's parade today. I'm going to be the downer of the entire group when I tell you some of the bad news related to what it is that we do and why it is that we do and how it is what we do and how we get paid for it. So I want you all in this audience to write down two numbers, because these two numbers are going to help you navigate through the morass of insurers and third-party payers, Medicare, Medicaid. One number is 76942. I want you to write down, everybody here, 76942. The other number is 77002. And it will soon become abundantly clear to you why I've included these two numbers. So 76942, 77002. I have no disclosures. Today we're going to talk about ultrasound as well as fluoroscopy, because you really can't have one without the other. They are apples and oranges after all, but how you approach your patients is directly linked to whether or not you're going to have a billable service to provide to that patient, in addition to being primarily safe and efficacious for that patient. We're talking about 8 distinct procedures and whether or not you can get paid for doing them. So it used to be so easy to get paid in interventional pain management until about the year 2010. We would perform our interventions, and regardless of whether or not we conducted those procedures under the use of ultrasound or fluoroscopic imaging guidance, we'd get paid. There was no such thing as bundling. Bundling is bad. This is the second take-home message today. Bundling is bad. Non-bundled or unbundled is good. And so what really happened? Well, what happened is that as the third-party payers began to be deluged and inundated by a morass of individuals submitting massive claims for every single thing, from trigger point injections to sympathetic nerve blocks to spinals and epidurals to the performance of intrathecal drug delivery systems and so forth, they started to take a step back and say, whoa, this is getting extremely costly here. And so they started to create brand new CPT codes which specified whether or not you could bill patients for imaging in addition to the actual procedures themselves. And so these new CPT codes now use specific language, including such verbiage as with ultrasound guidance or with imaging. But remember that once you begin to bundle, you are reducing payments. Every time you see the term bundling, nobody's doing you a favor, even though there'll be some arguments that so-called bundled procedures like SI joint injections or lumbar transforaminal injections, they might be paid at a little bit of a higher rate, especially if you're doing them in your office rather than doing them in the hospital. But in essence, when you see bundling, that means that the insurance company has taken a stance not to give you extra money for doing what it is that you do, which leads us to my main topic. If you're not going to get paid for doing what you do, why would you do it? If you can't get paid for doing an ultrasound guided block, why would you select ultrasound? There has to be a compelling reason in terms of patient safety or efficacy before you elect to perform that technologically advanced procedure on behalf of your patients. This is a very important slide, and this is the good news. These are the procedures that are unbundled. Yay! These are the things that you can do under either ultrasound or fluoroscopy and still bill separately for. So you see that there are some recognizable things there. And interestingly, of course, trigger points, which are at the low end of the spectrum in terms of reimbursements, you can do them under ultrasound and bill separately for ultrasound and get paid. Or even under fluoroscopy. I don't know how many people would do trigger points under fluoroscopy. Seems to make no sense, but you can actually submit a claim for that. And if you look at the bottom, this is Medicare in Illinois. So of course it's going to be a little bit different in every state, but this is a federal program, Medicare. 76942. That's one of the two numbers which is going to be very important to you as you leave this room and go back to your practices. That determines whether you can bill for ultrasound. 77002 is fluoroscopy. Look at intercostal blocks and stellate blocks, and if you see in the blue at the bottom of the page or the bottom of the screen, that determines the approximate reimbursement for these procedures if you use ultrasound. So it's about $60 if you do a stellate ganglion block and add ultrasound to it. It's about $107 if you do a stellate ganglion block and add fluoroscopy to it. Dr. George Cheng Chen pointed out, I do both. I'm not stupid. I do a little bit more under fluoroscopy, and if you see why now, you'll understand that I get about $50 more for doing my stellate ganglion block under fluoro than with ultrasound. Now, that doesn't mean that I ascribe to the fact that I believe that fluoroscopy is inherently safer. I do not, per se, and I'm going to show you why we make clinical decisions. Obviously, we are clinicians here. We're not economists. We're not necessarily good business people in medicine. But you need to know what's going to drive your practice, pay the lights and pay the electricity, and also pay you a little bit of a stipend at the end of the year after you pay your exorbitant taxes to the government, both state and local. This is a very important slide. Please keep this under advisement. These are bundled procedures. B, bundled, bad. This is bad. This means that you cannot use those two codes, 76942 or 77002, to separately and distinctly submit a claim to a third-party payor with the expectation that you're going to get something extra and above it. But if you look, and especially SI joints, lumbar epidural, cervical, transforaminals, facet joint injections, you're not going to be able to bill separately. The caveat is that with some of the joint injections, you do get paid a little bit extra if you use fluoroscopy. Now, that may seem inherently unfair to this distinguished audience of amazing speakers who are very facile with the use of ultrasound, and I didn't make the rules. So let's take a look at one of the examples. This is the kind of language you see with the common procedural terminology codes that are available to you. And when you submit these codes, you'll see that it says ultrasound is included. That doesn't mean that you get to bill extra for it. That means it's included in the base price for your procedure. But that doesn't mean you can't use fluoroscopy. In fact, in several cases you can. I'm going to go through them. So small joints, intermediate joints, large joints. If you use ultrasound, you will not be able to bill separately and distinctly for that. Bundled, bad. Again, facet joint injections, radiofrequency, or any type of neurolytic procedure cannot bill separately and distinctly for your radiological imaging, whether or not you use ultrasound or fluoroscopy. Cannot bill separately, will not get paid for doing so. Neurolytic facet joint nerves of the lumbar or sacral region, regardless of how many levels that you apply. Now, you can see that the government has taken into consideration that these are higher acuity procedures, so the reimbursement, especially in your office, is going to be somewhat higher than for other procedures that we do. Look at for neurolytic facet joint nerves, $449 if you do that in your office, and that's for the cervical or thoracic, versus $245 if you do it in the hospital setting. Again, food for thought for those of you who are considering becoming hospital-based or opening up your own private practices. Now, the next slide I'm going to show you is also very important. I'm going to talk about unbundled versus bundled. Unbundled, of course, is good because you get paid for both things. You get paid for the procedure as well as paid for imaging. And it doesn't matter whether you select ultrasound or fluoroscopy, you're going to get paid extra. In fact, fluoroscopy tends to pay more than ultrasound. This is a very important slide. Please take note of this. These are 8 procedures we're going to go through very rapidly today to talk to you about what the medical rationale might be for you selecting ultrasound over fluoroscopy. Does any literature exist to suggest the use of one modality over the other? Where I put a plus, that means unbundled. That's good. That means you do a stellate ganglion block, you're going to bill separately both for your fluoro or for your ultrasound. You do an intercostal nerve block, you're going to get billed, you can bill separately for the procedure as well as fluoro or ultrasound. If you're doing joint injections, you get paid or you can be billed separately when you use fluoroscopy but not ultrasound. And of course for things like caudal, SI joint injections, lumbar, cervical, thoracic, epidural injections or transforaminals, facet joint blocks, medial branch blocks, radiofrequency, you cannot bill separately. You cannot apply 76942 when using ultrasound. You cannot apply 77002 when using fluoroscopy. Remember those numbers. These are very important numbers, especially for those young people in the room who are finishing your fellowships going out to practice. You must know and understand 76942 ultrasound, 77002 fluoroscopy. So stellate ganglion block, why would you choose one modality over the other? Clearly, in this day and age, we would always use imaging. And why would we choose to use ultrasound over fluoroscopy? I'm going to show you. But you can see here, this is an unbundled procedure, the stellate ganglion. You can use fluoro or you can use ultrasound. Fluoro will pay you about $107 in Illinois through Medicare and about $60 when you use ultrasound. We know that we can see more with ultrasound. It makes sense. It's a marvelous technique, right? We take this approach from lateral to medial. We can see things that we could, aforementioned, never see with fluoroscopy. I can't see the trachea with fluoroscope. I can't see the esophagus. I can't see the thyroid gland. I can't see the sternocleidomastoid muscle or the longus coli muscle. Moving laterally as I go across the transverse process, which I can see with fluoroscopy, I find the longus coli muscle, one of the main anatomical landmarks for stellate block. In some cases, you can reconcile the arteries, the veins. You can't see these structures with fluoroscopy. You can see these structures with ultrasound. Needle comes in, you do your injection here, and you've done it under either fluoro or ultrasound. This is what the fluoroscopic imaging looks like. Again, you're seeing shadows, two-dimensional representations of three-dimensional anatomy, black and white shadows. But that really doesn't reconcile some of these important structures, especially vascular. And this is the lateral view showing an appropriately placed needle at C6 for stellate ganglion block. So we would think that ultrasound would eliminate complications, but in point of fact, that clearly doesn't happen. This is from Professor Hariharan Shankar, a great friend of mine, who has reported several instances of side effects and complications with ultrasound-guided stellate ganglion blocks. Here's a brachial plexopathy that happened in a 43-year-old individual who was undergoing multiple stellate ganglion blocks for complex regional pain syndrome. He got hurt when ultrasound was used. So ultrasound didn't prevent an injury. What we do know from Siegenthaler, and you heard Agnes talking in great detail about Siegenthaler and that work from that group, this is a comparison of what we can see with ultrasound that we could never see with the use of fluoroscopy. You can find the esophagus. 1/3 of the time we're going to see it with ultrasound at C6. 2/3 of the time we're going to see the esophagus at C7. We're going to see the vertebral artery. Right? We don't want to encounter these structures. The problem is that even seeing these structures doesn't translate necessarily to greater efficacy or greater safety. So it seems intuitive and inferential. If you see something and you avoid it, you should be doing better. But in point of fact, you're not going to get paid more for seeing those things. And this does not translate in high level of evidence peer-reviewed literature. How about peripheral joints? I told you that if you use ultrasound imaging for your peripheral joints, that Medicare is not going to reimburse you. But you can get reimbursed at a higher rate using fluoroscopy. Doesn't seem to make sense, but these are the codes. Fluoroscopy is payable in addition to the payment for the procedure performed, and you can see here, I'll talk about the acromioclavicular and the glenohumeral joint. You're not going to get more money to do an ultrasound-guided technique of these joints of the shoulder. But is there any clinical data which would suggest that you may want to offer this to your patients? So here's what we're looking at when we're using our sonoanatomy. We're finding the fibrocartilaginous disc, which is between the acromion and the clavicle. We can see our needle coming into the joint space at the level of the fibrocartilaginous disc. And here's what it looks like when we use fluoroscopy. Pretty easy joint to see. You put a small 25 gauge, 3/4 inch needle right in it in most people, and you inject a little bit of contrast. And so this is what the sonoanatomy looks like when we're talking about the glenohumeral joint. So again, in the shoulder, you can use sonoanatomy. You're not going to get paid extra for doing so, but you may get paid extra for using fluoroscopy. We see the infraspinatus, the glenoid process, the deltoid muscle, and the remainder of the rotator cuff. You can see all these things under ultrasound. Here's our needle pathway aiming for the glenoid process. And so is there any data which would suggest that we should offer ultrasound to our patients when performing shoulder injections? This is actually a meta-analysis systematic review of glenohumeral joint injections that showed that ultrasound was actually somewhat superior to getting your needle safely in the joint, 93% versus 80% with the use of fluoroscopy, but it was not statistically significant. So first, you're not going to get paid extra for using ultrasound for glenohumeral joint injections. Statistically speaking, you might be a little bit higher level of success. Does that translate to offering this technique for your patients? You have to make that decision for yourself. Intercostal nerve injection, bundled or unbundled? Show of hands in the audience. Is this a bundled procedure or unbundled? Unbundled, good. This is good. That means you get paid for doing your intercostal nerve blocks regardless of whether you elect to use ultrasound imaging or fluoroscopic imaging. So here's what it looks like here. Intercostal injections. Imaging is payable in addition to the payment for the procedure performed. 64421 intercostal nerve blocks. Here's what it looks like under ultrasound. Why would you choose ultrasound? Is there any data to suggest that regardless of payment with this unbundled procedure, where you get paid about $60 using ultrasound and about $107 using fluoroscopy, why would you choose one or the other? Well, this is what you can see with ultrasound that you can't see with fluoroscopy. You see the internal intercostal muscles, the intercostal artery, the innermost intercostal muscle, and perhaps most importantly, you see the pleura of the lung. Obviously, we do not want to encounter this bad boy when we're doing our intercostal nerve blocks. And so is there any data to suggest or substantiate that we might want to use ultrasound when performing intercostal nerve blocks for our patients? So this is a cadaver study done by Mike Gofeld. He's been a notable presenter at this distinguished meeting, and Mike published this in Regional Anesthesia a few years ago. It was a cadaver study. Took 6 cadavers, 12 intercostal nerves on either side, injected latex under each side, and then dissected the cadavers and found that when compared to palpation techniques, ultrasound was much more highly successful at getting your needle and the medication injected into the intercostal groove and space. But remember, this was not comparing fluoro to ultrasound. This is ultrasound versus palpation techniques. So we know ultrasound is useful, it may be safe, and the efficacy may be high. What about intra-articular injections in the hip? Is this bundled or unbundled? Well, if you use fluoroscopy, it's bundled. It's unbundled. If you use ultrasound, it's bundled. So how do you make a clinical decision for your patient whether you use ultrasound or fluoroscopy for injecting the hip? Again, this is a code where fluoroscopy is payable in addition to the procedure, but ultrasound is not. And the language is very precise. If you read the common procedural terminology language, it says, without ultrasound guidance. Fluoro is okay. Same thing for intermediate joints. Without ultrasound guidance, fluoro is okay. Major joints, like the hip, we're going to talk about that right now. Okay with fluoro, not going to get paid an extra rate when you use ultrasound. This is what ultrasound looks like for your hip injection. You can see the acetabulum, the femoral head, the femoral joint space, which is the target for our injectate. And this is what it looks like under fluoroscopy. Again, you can see a lot of stuff with fluoroscopy and injecting the hip. I think it's a wash whether you elect to perform these techniques under fluoroscopy or under ultrasound guidance. Is there any data to suggest the choice of ultrasound versus fluoroscopy? And this is a journal that I'm sure we're all very familiar with, Revista Brasileira de Reumatologia, that showed the effectiveness between fluoroscopy and ultrasound. This is a prospective study of 71 adults and found that there was pretty much a wash whether you injected a hip using fluoroscopy or ultrasound, but use something. Don't do what the orthopedic surgeons do and just do blind palpation technique. Joint flexion was a little bit better with fluoroscopy, but pain VAS reduction was a little bit better with fluoro. Both techniques work, fluoro or ultrasound, for injecting the hip. What about knees? Is it bundled or unbundled? Well, if you use fluoroscopy, it's unbundled. You can add fluoroscopy to your knee injection. You can't add ultrasound and bill separately for adding ultrasound to your knee injections. Here's the language. Again, arthrocentesis, small, intermediate, or major joints, without ultrasound guidance. So for some reason, Medicare has an aversion to paying you for ultrasound, but they will pay you for fluoroscopic knee injections. Does it make any difference to offer your patients a knee injection under ultrasound or fluoroscopy? Well, clearly you can see things with ultrasound that aforementioned you could not see using the use of fluoroscopy. Here's the vastus lateralis, rectus femoris, vastus medialis, and intermedius. You can see a lot of stuff when you use ultrasound. You can look inside the knee joint and see the medial and lateral menisci, the medial collateral, lateral collateral ligaments. You can see this with ultrasound, but you can't get paid for what you see unless you use fluoroscopy. Here's the knee injection for one of my patients. What am I really seeing? I don't know. I'm not seeing the meniscus. I'm not seeing the ligaments, but I'm injecting and getting paid at a higher rate for doing the procedure under fluoroscopic guidance. Is there any data to suggest any superiority of one technique or the other? Well, we don't have a head-to-head comparison between fluoroscopy and ultrasound guidance for knee injections. We do have the use of ultrasound versus what the orthopedic surgeon colleagues do, where they just palpate that little space and stick a needle in, have no idea what they're really doing. Ultrasound, very high success rate of getting your needle directly into the joint space of the knee, and certainly higher than when we use blind techniques, but you can't get paid for it. George Cheng Chen gave some great data about the genicular nerve block. Here's a very recent paper just published this year in the journal Pain Physician 2019 that showed that if you use fluoro ultrasound, doesn't matter for your genicular blocks, very high success rate regardless, but you're not going to get paid with using ultrasound. So you have to make a clinical decision based upon safety, based upon efficacy, but also based upon reimbursement. Okay, how about, and this is kind of one of those slippery slopes where this is an unbundled procedure, trigger point injection. So you can use ultrasound or fluoro for a trigger point. I don't know who would do that, and you'll be reimbursed regardless of which technique you use. You could refill your intrathecal pump under ultrasound guidance and get paid for it, not with fluoroscopy. So here's one utility where the use of ultrasound definitely is superior to the use of fluoroscopy. Bundled. Bundled means you do not get paid extra for adding those codes. Remember those codes, 76942, write them down, ultrasound, 77002, fluoroscopy, memorize them. So for epidural steroid injections, cervical, caudal, lumbar, or thoracic, you're not going to get paid extra whether you're not use fluoroscopy or document it or send that code in or use ultrasound guidance. Interlaminar injections, SI joint injections, facet joint injections. So why would you select ultrasound over the use of fluoroscopy? Let's go to caudal injections. There's our sacral hiatus and our sacrococcygeal ligament. This is a fluoroscopic view using a caudal block. Again, you can see certain things with ultrasound that you can't see with fluoroscopy. You can see your sacrococcygeal ligament, but you can see the caudal canal with fluoroscopy. Here's an ultrasound image. This is a lateral image showing the needle in the sacral hiatus, sacrococcygeal ligament in the caudal space. And this is one of my patients with a non-catheter caudal injection directly through a needle. Doesn't make any difference whether or not you use ultrasound or fluoroscopy for your caudal injections, notwithstanding the lack of reimbursement for either technique. Nice study that came out of China, 120 patients. Pain and oswestry disability indices both changed identically whether you used ultrasound or fluoroscopy. Another study, also out of, this is out of Korea, 110 patients, same exact thing. Whether you used ultrasound or fluoroscopy, patients got better. They reduced their pain, they improved their functionality. The most recent study, caudal epidural steroid injections, post-laminectomy patients, a small group of 30 patients. Half the patients, or 15, had their procedure done under ultrasound guidance. Half had it under fluoroscopy. No statistically significant change whether or not you used ultrasound or fluoroscopy. SI joint injections, not going to get paid for the use of imaging. Don't try to apply 76942 ultrasound. Don't try to apply 77002 fluoroscopy. Just do it because you have to do it. But is there any difference in efficacy or success? And here again, you can see this is this is a bundled procedure. This is what the SI joint looks like under ultrasound, pretty cool. You can see the ilium, you can see the sacrum, you can see the needle track, and of course, this is what it looks like under fluoroscopy. You can see almost all of the same types of things. Is there any data which might influence your clinical decision making? SI joint injections, 120 patients prospective study. Actually, fluoro did a little bit better than ultrasound here, a higher success rate of assuring that the needle was actually in the sacroiliac joint, but no differences in outcome. Controversial topics in the last 3 minutes. Transforaminal injections, cervical spine, that scares me a lot when you use ultrasound it scares me a lot when you use fluoroscopy too, so I don't even do them any longer. Transforaminal injections, cervical spine. Agnes talked a lot about head and neck stuff. Here's where fluoroscopy is included, meaning this is a bundled procedure. Again, and also for the zygapophyseal or facet joints. We're going to go through this. Ultrasound, fluoroscopy, guided procedures, lower lumbar medial branch injections made no difference. Made no difference whether you used ultrasound or fluoroscopy in terms of efficacy, in terms of side effects, and in terms of functionality or improvement in functionality. So you can use ultrasound for lower lumbar medial branch blocks. How about in the neck? This is cervical transforaminal injections in the neck using ultrasound imaging, comparing it head-to-head with fluoroscopy. This is a great study. 120 patients, there was no difference in pain reduction, there was no difference in success rates, and you could identify using ultrasound some of the vascular targets that you can't see with fluoroscopy. So when you're considering safety, maybe there's a role for ultrasound use. Not going to change your reimbursement, can't apply 76942 and say I want to get paid more because I can see these vessels. Can't apply 77002 for fluoroscopy, not going to get paid more. How about this? Deep cervical plexus block for cervicogenic headache. Ultrasound versus fluoroscopy, no difference between the groups. This is what you see in many of our studies that are highly rigorously conducted, that there's not going to be a big change in outcome. There's not going to be a big change in safety, at least not yet. So how do you make your clinical decisions for your patients? Now, this is how the procedure is actually performed. Agnes talked about this in great detail. She asked the room, how many people in the room actually perform these procedures? 1 or 2 hands went up, because most of us are scared to death. In fact, I'm not scared of many things. Well, I'm scared of this. This scares me a lot. I dream about this a lot. But I'm not scared of many things, but I'm scared of those procedures. And she also pointed out a nice letter to the editor from Buvanendron and Rathmel that urged caution for trainees just coming out in their practice about selecting the use of ultrasound-guided approaches for cervical blocks, head and neck blocks. This is a daunting task. This requires not just a weekend course where you go and Agnes or George Chang Chen holds your hand and holds your hand on the ultrasound and you think you're an expert. This requires months and years of practice to be facile and to be safe. So let's just go through a couple of final things, and I'm going to finish in the next 40 seconds. Remember that a bundled procedure may give you a higher rate of reimbursement, and so we see things like SI joint injections 27096 or lumbar epidural steroid injections. You're going to get paid higher if you do this in your office than if you do this in a hospital setting. Unbundled injections. Make sure you understand 76942 ultrasound, 77002 fluoroscopy. Know how to apply these. Because for those trigger point injections, you look what it does to the price. It doubles your reimbursement if you use ultrasound guidance for your trigger point injections. Or if you look below that, intercostal nerve blocks, it increases your payment. Whether you use fluoroscopy or ultrasound, you've got to document that. You've got to submit those as claims to get paid for them. Those are unbundled procedures. Remember, unbundled is good, bundled is bad. That's my take-home message for you today. And before I finish, please, I have to remind you, stop at the booths, go visit with the exhibitors before you get your coffee, and also look at the abstracts. A lot of people worked very hard to create great scientific information for you at this amazing meeting. Ultrasound is proven to be safe, but we don't really know how safe it is. Bundled procedures, bad. That's becoming more common. That's the future in medicine. That's our Kool-Aid that we're going to have to swallow as we go forward. You have to fight at a legislative level. Join ACIP, join New York SIP, New Jersey SIP, make a noise, pay money. We need to have a great coding specialist if you're going to go out into private practice that helps you navigate these treacherous waters, and the data is still accruing. Thank you for your time and attention. Have a great meeting. Break. Abstracts and break. Abstracts and break. Pictures for all the speakers. Can they please come forward? All the speakers.
For a 62321 and a 62323, only can do it